Hello, everyone. Good evening from Goa. Thank you so much for joining us. We have Dr. Tracy McPherson with us from University of Chicago, and she will be presenting um, the effects of adolescent SBIRT education using simulated learning technology in health professional training. I will quickly orient you to our tabs here. On the right side of the screen, you'll find the chat box where you can type in your questions, comments, anything you would like to share with Dr. McPherson. And we can address any of the questions you have towards the end of the presentation. The presentation will be of 15 minutes, and after that, we'll have a 5-minute window for discussions. We'll take up your questions. You can raise hands if you want to join Dr. Tracy on stage and have a chat with her. I will be happy to connect you all. All right. We'll wait for another minute because we are a little ahead of schedule. So we can begin in a minute, Dr. Tracy.
That sounds good. Thank you.
You're welcome. All right, we can begin.
Okay, great. Well, thank you. And welcome. Thank you for the opportunity to present the results on our study, examining the effects of adolescent SBIRT education using simulated learning technology to train health professionals. So this work is made possible through funding from the Conrad and Hilton Foundation and in partnership with CSWE, AACN, and Cognito. We have no conflicts of interest to report. I'm Tracy McPherson. I'm a senior research scientist at NORC at the University of Chicago, and I'm the PI on the project. And my co-authors on the presentation are Weiwei Liu, who conducted the quantitative analysis with the assistance of Jackie Sheridan, and who is our senior research analyst, and our project manager, Hildy Cohen. So first, let me give you a very quick overview of the project. The Adolescent SBIRT project was launched a number of years ago, back in 2014, and involved a lot of different experts, researchers, educators, practitioners. And we worked with them to develop and to design an adolescent SBIRT curriculum and our various implementation and evaluation tracks and what those would look like. We also launched a learning collaborative of nursing and social work education programs and other programs that did interprofessional education. And we work with them monthly to share resources and experiences implementing the curriculum. Right now, we have 6 implementation and evaluation tracks to accommodate the different types of ways schools and organizations implement. And right now, we're going to focus this presentation on one of our tracks, so that you can learn a little bit more about how academic programs implemented over the course of a year and some of the findings from that implementation. So this, as I mentioned, we had many schools in the Learning Collaborative. We have over 200 schools of nursing and social work who are implementing the education. And I'm going to be focusing on a track we fondly refer to as Track C, called our Academic Program Implementation and Evaluation track. We were fortunate to be able to present findings at the last Inebria conference we attended on another track. So if you are interested in learning about those findings, please let us know. We're happy to share. The academic programs in this particular analysis implemented over the course of a year, from fall 2016 to 2017. As you can see, there are about 18 different programs. All of them implemented during this time frame. All of them participated in the pre-post evaluation. So in this track, the faculty administered an online pre-test evaluation survey prior to and after implementing the adolescent SBIRT curriculum. And the curriculum and the implementation materials were drawn from the Learner's Guide to Adolescent SBIRT and an online simulation called SBI with Adolescents. The curriculum is very comprehensive. There are modules that cover screening, brief intervention, referral to treatment, and motivational interviewing. There's an extensive selection of resources on screening tools, scripted interactions, case studies, role plays, and so forth. There's also a companion training delivery slide deck that educators use to deliver the training. And it's wrapped around with an extensive website of resources where you can see sbirtweb.webs.com, and you can access the curriculum and all of those materials on our website. When you access this, you'll be able to get a copy, an electronic copy of the full guide. You can also request a copy of the full training slide deck. So the curriculum also includes virtual simulations. The one that was implemented with this track is SBI with Adolescents. It was developed in collaboration with Cognito, and it's an interactive role play simulation. And it's designed to prepare health professionals to conduct SBIRT with adolescents and young adults. So it includes didactic and experiential learning opportunities. There are 3 simulated encounters. 2 are for learning and practice, where they receive feedback and coaching along the way. And then the 3rd is a skills assessment simulation, where they navigate the brief intervention using motivational interviewing strategies on their own. And we take off the training wheels, we take off the coach, and they need to navigate it, and they get performance feedback at the end. And that way they can do additional learning, go back through it, and refine their skills, and so forth. The programs in this track did implement both the Learner's Guide modules and the simulation in whatever way they decided to implement them. There's a great deal of flexibility. For the methods, we were really interested in understanding whether there were significant differences in key learner outcomes, in particular attitudes, confidence, readiness, competence, knowledge, and skills to conduct adolescent SBIRT after the training compared to prior to receiving the training. We were also interested in any subgroup differences, looking at different program levels, maybe the implementation format, like the classroom setting, and dosage, the number of hours of SBIRT education that they received. So in this sample, we had 556 students who received the education across those 18 programs and took the pre and post test surveys. Most of them, as you can see, were nursing students, but we had a substantial number of social work students as well, and some who identified as interprofessional students, meaning that they were likely taking both social work and another discipline, or nursing and other discipline courses. So, but most of them all had at least some connection to a nursing or social work program. So about half of these were graduate students, master's and or a combination of PhD students. And all of them had some prior exposure to training. So, many of them, you can see, had substance use training of some sort. We don't know how much, but they did report having some. A little more than half had some exposure to SBIRT. Could have been adult, could have been adolescent. We don't know for sure. And then over half had exposure to motivational interviewing training as well. And among this group, 96% completed the simulation. So here's a breakdown of past training by program level. So a higher percentage of graduate students reported prior training across the substance use, SBIRT, and motivational interviewing. Probably not very surprising. When we analyzed the differences by program group on the outcomes, there was no significant difference that emerged. We conducted quantitative analysis of the effective training, and we were comparing pre and post scores on those key outcomes of interest, as I mentioned. And then we wanted to look at outcomes by implementation format, that classroom setting, and the dosage, using regression, regressing the pre-post differences on each outcome on independent variables. So our outcome measures. Very briefly, I'm going to review these, but if you'd like more information, please don't hesitate to contact us. This is an adapted measure of the BSAS. There were 7 items that really hung together in our psychometric analysis, which we replicated over time. And so we used this in this particular implementation track, and higher scores suggest more favorable attitudes. We examined confidence and ability to conduct SBIRT, and students rated on a scale from 0 to 10 how confident they were in performing 9 substance use related aspects of SBI, such as assessing an adolescent's readiness to change. We also assessed readiness. There were 4 items that were rated on a scale of 0 to 10. For example, how ready they felt in conducting screening or providing brief intervention with an adolescent. And then we assessed competence. These are perceptions of their competence. And they were asked to rate on a scale of 1 to 4 how confident they felt in performing 17 substance use related aspects of SBI, such as asking adolescents about quantity and frequency of their alcohol and drug use. And knowledge. We had 9 total knowledge items that aligned with both the Learner's Guide curriculum and the simulation. And they asked both about SBIRT and motivational interviewing, and the higher scores indicated more knowledge. We had a skills case scenario. There were 19 questions or statements, and learners had to respond to assess their ability to apply motivational interviewing skills when delivering a brief intervention. And so the results. Overall, the results of our t-test with a sample overall showed that there were no changes in attitudes, but there was a statistically significant and positive change in competence after the training, as well as confidence and readiness. In fact, there was a 2-point change in readiness over time.
Dr. Tracy?
Yes.
I just want to remind you that we have 5 minutes more for the presentation, and then we'll take up the questions.
Okay, terrific. So as you can see, the results suggest that the training has a positive and meaningful effect on the students' perceptions of their competence, readiness, knowledge, and their skills. When we looked at implementation format, we wanted to look at classroom setting, look at in-person, online, and hybrid, whether they had taken the Cognito simulation and completed it with 80% or higher, and the number of hours of SBIRT that they had been exposed to in terms of the curriculum. And those were grouped to 2 or less, 3 to 4 hours, 5 to 7, and 8 or more. And some of the descriptives from program implementation, you can see that most delivered the curriculum in person. 80% had completed the simulation, at least 80% or more. And you can see there's an interesting split between 2 hours, 3 to 4 hours, 5 to 7 hours, with fewer providing over 8 hours with an average of about 5 hours of education. Okay. So we conducted regression with the dependent variable being the pre-post difference for the program implementation data. And the dependent variables were constructed by subtracting the pre and the post test, pre from the post test. And we regressed the pre-post difference on a series of independent variables to examine whether the observed subgroup differences were significant. And separate regression models were run for each outcome of interest. And what you can see here is that the in-person education yielded the largest improvement on competence and readiness. For confidence, no significant difference in improvement between classroom settings, simulation completion, or dosage emerged. And for readiness, students who received in-person education improved more, and the magnitude of that change was higher for in-person than for online or hybrid. Okay, so controlling for the setting and whether the simulation was completed, those who had 5 to 7 hours of SBIRT education compared to those who had 2 or less saw a larger improvement on knowledge. For knowledge and skills, the magnitude of improvement was not significantly related to the setting or the completion of the simulation. Okay, to look a little closer at the data, we examine the differences between the dosage categories and competence, confidence, and readiness. We first conducted t-tests comparing the pre-post score for each outcome. And as the red box, text box indicates, all the outcomes and across all dosage groups, the post scores showed significant improvement compared to the pre-score. The p-value of less than 0.001 is the p-value in the red text box that refers to the pairwise t-test comparing pre-score with post-score within each individual. And that is regardless of dosage, all students showed an improvement on the outcomes of interest. And then the table shows the comparison across dosage groups. And so the p-values in the table refer to the independent sample t-test comparing across the groups. As you can see, for most of the pre, the post, or the pre-post difference scores, the difference across the groups are not significant. For example, competence and readiness, the pre-time point does not differ by hours of SBIRT. The exception to that is confidence. So the score differs at pre, but does not differ at post, which is interesting. And this suggests that although students with fewer hours of SBIRT started lower, they caught up. And it seems that their improvement is larger compared to those with higher SBIRT hours of education, but they are not significant. It could be a power issue, but this at least points to the direction that even with fewer hours of SBIRT, you will see an increase in confidence. Okay, and last but not least, for knowledge, we see that the difference between pre and post scores was statistically significant within each SBIRT dosage category, with 5 to 7 hours of SBIRT education yielding the highest improvement on knowledge. For the skills case, the mean difference for each category of hours of SBIRT education was not significant, and students ended up with similar level of improvement, no matter how many hours of SBIRT education they received. Okay, so some overall conclusions. Overall, we saw some improvement on key learner outcomes, with the exception of attitudes, of course, which can be fairly difficult to move in a fairly short period of time. But the other outcomes, we certainly showed some overall improvement. The classroom setting, dosage, and cognito completion were all related to improvement in some way. For example, the in-person training saw the largest improvement on several outcomes. Those who took the simulation saw larger improvement on several outcomes, and training programs with 5 to 7 hours of SBIRT seemed to yield the largest improvement on knowledge. And so We'll continue to analyze this data. We're still sitting on lots and lots of data. We've replicated this track and are still looking at other implementation tracks as well, and hope to be able to share those findings at a future Inebria conference. But I suggest to some degree, with flexibility, allowing for flexibility of implementation, the adolescent SBIRT education, including the simulation, can have a positive effect on student outcomes as they prepare to implement adolescent SBIRT. So future directions, very briefly, we're hoping to examine the long-term effects to see whether they're sustainable over time, whether the change in the impact of the training impact their practice behavior after they graduated. And we will continue to look at the dosage effects across the different tracks and see whether the time in the simulation had any effect. And last but not least, we'd like to see whether there are specific skills that are demonstrated in the simulation, assessed during the competency assessment, had any relationship to the outcomes. All right, so thank you so much for listening to our presentation. And let me stop sharing my screen, and let's see if there are any questions in the chat box. Let's see. Okay. I don't currently see any questions at the moment.
Hello, everyone. We are looking forward to hearing from you all. You can also raise your hands if you want to come and chat with Dr. Tracy on stage. All right, it looks like there aren't any questions.
Okay. Well, thank you so much. I appreciate it. And for listening to our presentation. And if folks have questions about the curriculum, how they can get access, or any other information about our measures, we have psychometric analysis that we're happy to share. Please don't hesitate to reach out to us. And thank you for joining our session this morning.
Thank you, everyone. Thank you, Dr. Tracy.
Thank you. Bye-bye.
Bye.